and a very good afternoon, everybody. After a two very elaborate talks by General Ikram and Professor Saqib, let's hope, if I can say at least something in a different way, if not totally different, because people say that my job has been made easy, but I think my job has been made difficult. So, as you all know that this is a very important flow chart. As the pandemic started as acute COVID, then ongoing COVID and long COVID cases joined in. And all this went on till the summer of 2022, when the worst of the COVID pandemic was thought to be over. That COVID hit back again, now in the form of making a union with other diseases in the form of a triple-demic, which hit during the winter of 2022 and 2023. And then in the middle of 2023, the pandemic was over. Now, right in 2024, where we are standing we have got cases of acute COVID with seasonal, especially winter surges. We have got acute COVID as a part of co-infection with other viruses, and we have got cases with long COVID. So since we have got all the different issues associated with COVID in 2024, so we need to learn to live with COVID-19 and keep ourselves updated regarding the management. The pandemic is over after killing more than around 7 million cases, but still there are more than 22 million active cases, of which 0.2% are critically ill, and there are more than 65 million cases of long COVID globally. As far as our part of the world, that is Southeast Asia, is concerned, COVID is still there with the winter surges, like the weekly cases of COVID-19, acute cases reported to WHO increased from 1,400 cases per week in July 2023 to 2,700 cases in January and February 2024. Then you know that the triple-demic, which actually was responsible for killing 0.1 million cases during 4 months of the winter of 2022 and 2023. Now, since there is an overlap between the symptoms of COVID and other viral infections, so if we are able to conduct the lab test, like we need to develop the culture of developing a lab test. Right now, we just go by our clinical decisions, and many a time we are a bit hesitant as a community to conduct proper lab tests, and this delays the timely diagnosis and initiation of COVID-19, which all you know that this is very important to initiate it timely, the treatment, so that the disease can be controlled, and reducing the risk of hospitalization and 28 days mortality. The best probably therapeutic option is remdesivir, that is IV, according to Pine Tree randomized study. So again, emphasizing the need to continued education about the risk factors, the prevalence, diagnostic factors, and treatment. As far as the acute COVID is concerned, the major risk factors are increasing age, then comorbids like obesity and diabetes, then status of being unvaccinated or not fully vaccinated and being immunocompromised. Then the 2 tests are available. PCR was done in huge numbers during the pandemic, but right now I think antigen test is the best option because it is cheap and it can be done very quickly. And if in case, although it's got a bit low sensitivity, so if it turns out to be negative, but if there is a strong clinical suspicion, so it can always be repeated. Then these are the basically 4 drugs available, 2 groups, that is RNA polymerase inhibitors and protease inhibitors. These 4 drugs are basically licensed actually for use in the US, UK, Europe, and Japan. So among the key messages, I would like to basically focus on one message, that is ongoing education on the risk factors, prevalence, testing, and treatment. RPTT. Remember RPTT. That is risk factor prevalence, knowing about the prevalence, testing, and timely treatment. So I'll briefly discuss the triple-demic, which is basically the convergence of three viral epidemics, that is respiratory syncytial virus, along with influenza and COVID-19 viruses. And this term was actually coined in 2023 just to describe the extraordinary surge of the trio of viruses during the winter before the last year, that is the winter of 2022 and 2023, giving rise to increased number of severe cases in the US. And the factors which were responsible for the severe infection in the triple-demic is that I would like to please focus on the arrows. The basic mechanism that has been brought forward to describe this triple-demic is the COVID immunity debt. And what is that? It is very simple, although the name is a bit complicated, but it's very simple. When the COVID restrictions were first imposed, that leads to lesser exposure to infections, not only COVID, but to other infections. So that less exposure led to less infection rate, which again in turn led to decreased acquired immunity. And so a state of decreased acquired immunity was established in the community generally. And when the restrictions were relaxed, this status of decreased acquired immunity combined with more exposure because of the relaxation of the restrictions, more people were suffering from acute COVID, and the infection was very severe. So as a community, we had to suffer severe infection to regain our lost immunity. And this is described as a debt, that is suffering in acute infection is described as a debt that we have to pay to regain our immunity. Now, during, as I've already alluded to, that during the winter of 2022 and 2023, about the triple-demic actually killed 0.1 million people in the US, and the hospitals were completely overwhelmed, and it disrupted the attendance at schools and workplaces and left families worried about their loved ones. Now, basically, what are the options that we, how to deal with the triple-demic? Fortunately, against all the three viruses, we have got the preventive option available in the form of vaccines, as well as treatment option available in the form of drugs. The best time, this is very important, to time the vaccination against flu and other infections in such a way so that the peak immune response actually matches with the peak of the flu season and other infections. And the best ideal would be to have a combination single-shot vaccine for all the three viruses. But until then, we can give flu and COVID vaccination simultaneously but separately. That is one on one arm and the other on the other arm. And since RSV is a relatively new vaccine which was discovered only last year, so we don't have much experience with it, so we need to place it at a space of at least 2 weeks from the other vaccines. And now coming to the long COVID, which was very nicely summarized by Professor Saqib, I would like to skip many of the slides, and then I will straight away go to the definition is there. One thing I would like to highlight here, again, the testing during acute infection, because as you know that this is a diagnosis of exclusion. So until and unless we had an initial diagnosis of acute infection, lab proven, we cannot say that this is long COVID, because for long COVID we have to have a lab proven diagnosis of acute infection in the past. So that is something which we need to take into account. And then there is a problem with the diagnosis of long COVID. It is often misdiagnosed as anxiety or panic disorder, because as a society we don't accept the idea of sick forever and permanent disability caused by COVID. Moreover, there is no diagnostic laboratory test available for long COVID, so that's why many of the people are misdiagnosed as anxiety or panic disorders. This has already been done, so I will just This is also has been done by the similarities between ME, CFS and long COVID. There are some specific symptoms which are special to long COVID and that are not there in other causes of ME, CFS. That is the decreased sense of smell and taste, that is special for long COVID, as well as rash and hair loss. And then the symptoms which are not a part of the long COVID but that are there for the other causes of ME, CFS, they are painful lymphadenopathy, chemical sensitivities, and tinnitus. Now, the pathophysiology, basically I would like to elaborate a little bit on this. Similar symptoms and pathology of ME, CFS and long COVID with other infection and major trauma. They can arise, and this raises the possibility of broader illness. That all these causes, multiple causes, cause basically a broader illness pattern in a particular person, like different causes, ME, CFS, long COVID, other viral infection, even major trauma can cause this pattern of illness. And the symptoms actually occur due to a carefully orchestrated, stereotyped, multi-system response to infection or injury. This is very important, that there is a well-orchestrated or planned, stereotyped, multi-system response to infection or injury. And these symptoms are generated because they lead to metabolic reprogramming as well as behavioral changes. They reduce energy consumption, non-essential activities, thus conserving energy to facilitate recovery from infection and injury. Like this, these set of symptoms, the one of the COVID and ME, CFS, they will cause the person who is suffering to reprogram the metabolic activities at cellular level as well as the behavior changes. Like he would not be feeling extreme fatigue. They would cause extreme fatigue, and the person would not be willing to even make slight exercises, whether mental or physical exercise. And the ultimate aim of this is to conserve energy, basically, so that the energy is not spent in unnecessary or less important activities, and it is spared basically for taking care of the injury caused by infection or by trauma. And the example of such a response can be seen throughout the animal kingdom to vital threats. And a good example of that is hibernation in frog, and then torpor in the brown and black bear of the north. So during cold weather, because of the acute shortage of food, these animals, they go into kind of a sleep mode, prolonged sleep mode during the winter months, and just to prevent or to conserve some energy so that they can deal with the difficult time. So this is the PEM and POTS. These factors have already been discussed. Now, PEM is basically worsening of symptom following even minor physical or mental activity occurring at 12 to 72 hours after activity, lasting for days, weeks, or months. So how to treat it? Basically, we need to plan our activity so that we remain within the energy envelope. That is, the energy envelope is different for different patients of COVID. Some people, they get fatigued after a bit relatively taking a bit of a walk, and some people even turning in the bed, that can cause fatigue. So they need to tailor their activity so that they don't get fatigued. We can forget about it, proceed further. And then this is basically the test as how to establish the diagnosis of PEM, that is post-exertional malaise. Basically, it's a specialized test to evaluate dyspnea in post-COVID and as well as in other patients as well. So it is done on 2 days, successive days. Like the next day, this is basically a combined assessment of cardiopulmonary system in response to exercise, and the next day it is found out that the PEM patient would not be able to exercise to the degree to which the patient did it in the past or the previous day. So that is something just to objective assessment of PEM, this is the equipment, which is a very complicated and comprehensive equipment, gas analyzer, ECG, pulse oximeter, and so many gadgets there which can assess the cardiopulmonary system together. I've got just a few slides. POTS is again there. Now, that has already been this again postural orthostatic tachycardia. The patient who suffers from this, the moment they get up from a lying position, they might be resting there for maybe hours and hours, and the moment they get it, so straight away they go into a state of tachycardia, maybe it's dizziness as well, and that tachycardia doesn't settle down, it persists for at least 10 minutes. And how to establish that is that, so either there is a 10-minute standing test, that is the moment the patient stands, you measure the pulse rate, the increase in the pulse rate, and if that persists at the 2, 5, and 10 minutes, then that is that just proves the diagnosis of POTS. And this has already been explained by Professor Saqib. Here, just on standing, there should be at least 30 beats, increased by 30 beats per minute, or a total number of more than 120 beats. Last, I will just emphasize again to remember that keep updated about the risk factor, prevalence, testing, and timely treatment. Thank you very much for your patient listening.
Thank you very much, sir, for